So good. It's morning or afternoon? It's afternoon. Thank you so much for the invitation. Great pleasure to be here today. So I prepared some few slides, but you heard about me as just few words. So I have been focusing on Pheochromocytoma Paraganglioma over 25 years. But approximately, 1 year ago, it will be 1 year ago in a few days, I moved from United States, from NIH, where I actually put together, it was like one-man company, the program focusing on Pheochromocytoma Paraganglioma. And we created there, the largest worldwide database, having about 400 patients per year. And approximately we collected about 40,000 samples. They are still sitting there. And so then I moved, from United States to the Czech Republic because I'm like a hybrid, so hybrids are very popular these days, yeah, as a cars, so, but because of my family reasons, that, so I moved to Czech Republic. However, I am very closely working with NIH practically on daily basis. And my successor is Dr. Hussam Al-Kaizi, who is extremely good, very clever, and I'm pretty sure he will be even better than I was. And but we still, as I said, working together, and for the next about 5 years or so. I promised my wife, to retire sooner, but don't tell her, I will not do it. So sometimes you have to play the game. And so, and I'm playing, so far successfully. And, so it's not for free. But what I wanted to say that, so I will be involved in Pheochromocytoma as well as new treatment options. I'm trying to put very sophisticated treatment options together, also with my son, who actually is not in healthcare, I have to say. He's in financial services, but he is very big supporter of cancer research, cancer patients, and we have some very good plan, to put together some very innovative therapy for metastatic Pheochromocytoma. Cross fingers, because if it's going to work, that will be very good. But of course, you never know the chance. It's maybe good, maybe low. So we are working on that right now. I also had the Center for Adrenal Tumors in the Czech Republic and National Consortium for Adrenal Tumors in the Czech Republic as well. So the idea of my wife, so moving, from United States to Czech Republic and being retired, disappear. But I think that, we still can do some very good things. So about me a little bit. And as I said, we have a very big database also at the NIH. It's important that you know about that, because when you were thinking about how to put things together in the future and maybe how to help, without you, we will not be able to do it, and you will not be able to do it without us. And artificial intelligence is coming. It's very important part, and I will show some few things that I think that what can be important in the future. At the end of my talk, which will not be very I would say very long talk, you have a choice. The first choice is we will finish, and that's it. The second, so you can ask questions, whatever you want. You can ask also question about yourself. And even, we will not have this gathering, because I don't know if we have this room, as a unlimited time or so. But you can come to me, and if you would like to share your story and you would like me to give you, some advice, how to be treated and what to do, so use this time. My time is unlimited. So at least until, for example, 4 4:30 because the meeting is finishing actually at 5 o'clock. I have to be there only to say few words. I don't like it so much, so because it's too official. But anyway, but I have to do it. But this international symposium on Pheochromocytoma we put together in 2005 when we had some existing vision and. To do it for you and to actually do also for physicians and to have very good interaction. And also we were behind Para Alliance as at the beginning when everything started, and we are very happy because this organization, especially for you, is doing marvelous job, and I'm proud of this organization because it's one of the leading organization in the world, and I think that we can do very good things. But as I said, if we don't work together very tightly and helping each other, especially in the area of the something which is rare, so we will have a very hard time to succeed, including clinical trials. So Dr. Delivera said and mentioned something about the clinical trials. And yes, we have some, but compared to some other cancers, is incomparable. Okay, we have a few, 2, 3, 4, 5. But if you go to other cancers, they have a 100, 200, 300, 400, 500. So we have to really helping each other. I can talk this way because I'm not anymore, a DNI. I don't represent federal institution, and I cooling period is over because it's 1 year. So, but this is how it is, and my goal is of course to help you, because I always tell my fellow, so not only in the Czech Republic, but I always did it also in the United States. We all will be patients. It's only a matter of time. Okay. So about the progress together about patient care, so the global collaboration in cancer research, especially cancers like PGL is essential and can greatly improve care and outcomes. So, but as you know, the PPGLs with Pheochromocytoma, Paraganglioma, faces challenges because we have a few patients, limited clinical trials, scarce evidence from single centers and countries, restricted funding, over reliant on patient or family-funded organization. The family-funded organization and all this organization, it's important, so how to say, so Para Alliance is doing great job, for patient on every year. We put together international symposium on Pheochromocytoma. We are partially funded with Para Alliance, but there are some other organizations who are actually, for example, putting together and organizing meetings. I'm not absolutely favor, sometimes of this, I would like to see, yes, every organization can do whatever they do, but once in 3 years or 4 years, we all should meet together and organize a very good, very nice meeting where patients will be also supported in terms of travel, in terms of, for example, accommodation, etc. And I think it can be done. So I will try to do as much as possible. And some they listen to me, some less. But I can tell you honestly, I think that will be good rather to have, for example, 2 meetings for related to or focusing on Paraganglioma in 1 year. That's not something that I like. I would like to have, instead of 3 days, maybe 4 days, but to cover also patients, to bring patients, from different countries as well, or even from far, because not everybody can afford it. And being patient, I understand, it's very complicated, very difficult, including financial value. So, robust guidelines of lab support from professional societies, but I can promise you that we are working on that. And I was rejected by Endocrine Society, by American Association of Clinical Endocrinology, by the International Society of Endocrinology. Oh my God, so name them. And so finally, we decided we will do on our own. And so we put together very good clinicians and very good scientists. We announced it already and also during this meeting. So I will head this activity together with another two very good clinicians, and we will be submitting proposal on Monday when I come back to the Czech Republic from short trip, from Canada to Czech Republic. It's only 16 hours, it's a piece of cake. So, but what I wanted to say that I will submit, for a very good journal. It's really first tier journal. Why it's important? Because, if we publish there, it will be for you. We are doing it for you. Okay, there will be general guidelines for Pheochromocytoma, Paraganglioma. It will not only going, to SDHX, MEN, VHL, etc. General guidelines. I think it's important also for you because you take the guidelines, you to go to the doctor and tell him you have to do this and that, okay? Because sometimes the doctors are reluctant and will tell you, I don't want to do it because, this is something, I never had. You will tell them, no, this is international, the guideline. This is in the, consensus. This is, what is supposed to be done because we have to prevent you, in a certain way. So we will start working on that. We will have a very good people. We are just, started talking, with those who will be, in the committees, and because there will be, subcommittees. And if everything goes well, we will have it, I would say approximately sometimes January or February. Okay. But we were refused, by professional societies. Here is, for example, something in case that, just now it's too late, but, in the future, if you have somebody, who's working in certain professional society or somebody, from the family or relatives or somebody who can help, in the future, it's always good, because otherwise, we will have a hard time, to succeed. But right now we at least find, some options. Global effort and international cooperation. We have to be global, not only international, equals global, but sometimes international is not absolutely global. I want, we be global. So which means establishment global these databases again, so if we don't have a volunteers, if we don't have a people who will help us or some gurus, who would like, to say, okay, I have somebody who is very good in computers, registries, databases, I will work, with the group. I will help them, so it will be very good because we have to collect data, and I will explain why we need to collect the data, shortly. Data sharing is very important, so whatever we discover, we have to give to public, okay? So that's important. When I was at federal institution, I think kudos to federal institution. We always, share all the data, to the public, which is very important, and many scientists are profiting from that. But there are still some schools or some universities, they may have, restrictions. Although I think that these days, everything is becoming a little bit better or maybe more than better, so because, sharing data is important. Coordinated large-scale clinical studies and clinical trials is very important. Look here, so the clinical trials on patients with breast cancer, colon cancer, 10,000 patients, without any problem whatsoever. Piece of cake, but for pheochromocytoma, we get 200 patients. Oh my God, so it's equal maybe to 10,000 patients, with breast cancer or colon cancer. So we need more patients, we need the patients, to participate in different countries. I know somebody would argue with me, but it costs money. Yes, it depends how everything is set up from the beginning, who is behind, what kind of, for example, company. Here also, if you know somebody, and not only you, because you are connected, you are very sophisticated. You are connected through the media and Facebook and everything, so and so it's important because somebody has, oh my God, have somebody who is, for example, the VP, or somebody who can, help with this and that. So because we need, so to support large scale clinical studies. Why? Because, the data are better, data are solid, we know, what to do, how to approach, everything. So just be aware of that. And unique effort to unite various professional and patient-oriented organization. I already mentioned that, so I don't like organization here, organization there, that, yes, they will exist and that's okay. That's no problem. But on the other side, we have to come up with, some, I would say, some plan, how actually these organizations can from time to time meet together, like, those politicians, yeah. They meet, around the table, I will not say oval table. So, but, they meet, and they sit around the table. That's exactly what is needed. We need, that the organization and Para is really doing great job. And it's not because I am in advisory board that I am, on the board of directors, but, so it's very proactive. But we need, and it's open. This organization actually is open to talk with other ones. So we need to bring otherwise from time to time and say every 3 years we will do, the meeting, once will be in Europe, once will be in US, once will be, let's say, in Australia, but we will also support patients because if we would do 2 separate meetings, we would spend so much money that those money we would support, for one meeting, we can actually give to patients and help them, to cover expenses. So it's also up to you, to help with that. Think about it. Talk, with your, I would say, I don't know maybe how I'd say it, not only friends, but those who are, connected through media, and maybe to create something interesting and something that will help. Okay, so that's how I view it. Then yeah, so only just, from the, when we started, this was called Spring Harbor in 2003, so I think that animation is a little bit off, but that's okay. That's not the most important. And then we put together immediately, Pheochromocytoma research support organization. This is the organization that is behind the International Symposium on Pheochromocytoma. That's behind, also this one. Although the organization is not well, I would say, very active, but because, everything started through this organization, it's fine. And then, we organize who said I had a dream, to those who are from US, about who I'm talking about. So we put together first international symposium in 2005, and we published, it was a landmark paper actually, so in first year journal, and that was very important for physicians, for the first time to realize, there is something, moving, in those tumors that are actually rare, but they are very complicated, very difficult, very also challenging, to be treated, and also to be treated, I would say, properly, because I saw many patients who were not treated properly, and sometimes it's actually too late. And especially, yes, sometimes I was very sorry for some patients who were actually Yeah, so this is what you know. But we also had, the first international congress on head and neck paraganglioma. Just wanted to let you know in Piacenza in Italy. And that was a very successful congress. It was about 200, there was 200 people. And we have to put together guidelines for head and neck paraganglioma. This is what is missing, very much. And we are very heavily working on that just now. We are starting working together the main parts, what is going, how everything will be structured, what will be, I would say, questions, what will be the answers, etc. So just wanted to let you know that something like that exists, and you will hear sooner or later that there is, the guideline in the preparation, and hopefully, will work very well. Will work well. And we will have a second congress, next year. It will be at the same place in Piacenza in Italy. I know it's in Italy. It's a little bit, far from, some countries, but the person who is helping, it's very good. By the way, he's one of the best surgeon ever. I saw, and I can tell you, I saw many surgeons, or I talked with many surgeons. What do we have? Only I saw that we can stay in for is there somebody else?
No, but we promised them we'd be able.
Yes, another speaker?
No, but we can move out in the hall. We just.
Yeah, I want this to talk a little bit, so what is? Yeah. Oh, they will eat here, you will eat here, or in a 20.
Just continue.
It's up to you. You decide. You decide. I by the way, I have not had lunch as well. Okay. So you decide. It's up to you. Okay. So, but this is the best, Professor Sana, Mario Sana. If you have somebody, especially those jugulotympanic paraganglioma or something, he is absolutely phenomenal, very phenomenal person. Okay. So always, if you have something rare, rare belongs to places where it is comes. Okay. So don't think that that the people will tell you, oh, we know a lot about the Pheochromocytoma, but this is Pheopara Alliance put together. It's extremely good, actually, program at the center of excellence. Because we are trying, to have at certain places people who have actually experience, from these tumors. As other guidelines, so you can see how many guidelines, we have. Right now, here's the guidelines, we put together just recently. These are about the SDHX tumors. Okay, so if you have SDHX, and if your doctor needs, something, just give him the guideline. And if the doctor has a problem, they can either contact Pheopara Alliance organization, or they can contact me. You have my email, so my email, easy to find, you go to PubMed. In the PubMed, every article has an email of the last author or the first author, okay? So it's not big deal. NIH account is not working because, things change a little bit in the United States, the way that, one day I woke up and I saw that my account, so the NIH, is locked. So I don't know why, but I still have Yahoo account, and it's over there. Okay. So and then we are preparing.
If you guys want to grab lunch and bring it back in here, you're welcome.
I think that we all will eat together.
Okay.
So, and international guideline for comprehensive look here. That is the pretty good actually title. International guideline for comprehensive management, including treatment and follow-up of Pheochromocytoma paraganglioma patients. You will have there everything. And I'm trying to put together the best minds ever, in the world, because this is the most important, you always learn from the best. Okay. So I think that would be good. So I'm pretty sure we will go well, and it's no geographical or other boundaries. I don't like any, the boundaries. I think, it should be conveyed to everybody So because we have to be respectful to patients like in, for example, Europe, in US as well as in Asia or some other parts of the world. Okay, so just wanted to let you know. So here, so also wanted to tell you that there is something about, Dr. Del Rivero mentioned, we just now are playing, with the immune system. We will hear about the immune system very soon because we are trying to develop new approaches how to use your immune system in your favor, okay? Because the tumors, for example, Pheochromocytoma, Paraganglioma, are actually or unfortunately are cold. Cold means that they don't have immune cells. So immunotherapies are failing right now. If somebody wants to offer you or your relatives or somebody, immunotherapy, be very careful, okay? Because usually those immunotherapies are not working, okay? But we have to come up with some, I would say, approaches, and we know about those approaches, how actually these cold tumors will be hard. Hard means that they will have immune cells, and then we will hit them with, immunotherapies. And Dr. Deli will talk about, for example, sunitinib, etc. Sunitinib is a very good study. Don't get me wrong. Unfortunately, sunitinib, we have to be very careful. Whoever has this SDHX mutation, so it may have, sometimes a little bit complicated outcomes using sunitinib. It's like honeymoon, honeymoon is honeymoon, so, and, well, so that's not last forever. But what I wanted to tell you, if use sometimes sunitinib, you have a really high period. Patients have a SDHX, especially they are responding, they are feeling well, but after certain time, it's getting much worse, even worse than the before. Okay, so be very careful before going into tyrosine kinase inhibitors, especially with sunitinib. It's not with every patient, but at least my experience when I was at the NIH for 25 years, my experience was not absolutely the best. If I could choose, drug, from TKI, tyrosine kinase inhibitor, I would use, for example, axitinib. The Dr. Pheochromocytoma, Dr. Del Rivero and other, using, so because the axitinib is, the drug that is better. It's not easy, to get it, but you can get this drug, for example, in the United States, I don't know, in Europe or in Canada. And then we have a belzutifan. Everybody is saying that this is miracle drug. No. So efficacy only 26%. CVD therapy, cyclophosphamide, that was in efficacy 80%. So choose. Okay. So yes, belzutifan may be sometimes good for some patients. Let's say what will be the article when they publish. I am not, the part, but preliminary, actually, I would say information through FDA, etc. Efficacy 26%. This is too low. If I take radiotherapy, what Dr. They were also talking about, the efficacy is approximately 70 to 80%. Okay. So yes, it will be good for some patients, but this is not related to you. You don't have that mutation. Okay, this is very specific mutation that is called HIF2 mutation. Then the drug is miracle. But for the other patients, yes, there will be always exceptions. By the way, in medicine, nothing is 100%. Okay. But there are exceptions. There are always exceptions, and some patients will tell you, I responded beautifully. We know because you are the outlier, you are the exception. But so you have to look at the whole picture. Changing minds is harder than adding skills. That I always tell, especially those who are, creating something new, some new ideas. And I wanted to tell you that we will be using, artificial intelligence. I'm very much into artificial intelligence. Do you like a GPT? That's great, yeah. You send the doctor, say, well, I would like to send the doctor, though this is my story, and then make it polite, and then they will tell you, I would you like to be a little bit stronger? Okay, try. Be a little bit stronger, go to the point, and for me, it's even better because, I'm not a person who was born in the US, English is my second language. So there are the different models, which is called predictive, we predict something, or generative model. When we have everything like about you, we already have SDHB mutation, we know what happened to you, what kind of treatment you had, we know about, your age, we know everything about you, and then you put everything into artificial intelligence and ask, what would you do with me? How do you view my situation? Okay, so it's not predictive, does not predict, but generate, something about you based on, the information that is already known. And I will show you something which I think that you will like, that's okay. We can go here. Some examples using Gen means generative, Gen AI, artificial intelligence. We can identify novel PPGL subtypes that will go beyond current molecular and other classification molecular, which means you have a mutation. It's already known. It's almost like obsolete these days. Okay, yes, there's a mutation. Did it help you having some mutation with the treatment? Actually, yes, but not to the greatest benefit. So you put everything together, and there will be, I am not copying Elon Musk, okay? But this is what I created, this one. Next, next generation tumor subtypes. So that would be fantastic. Can you imagine? We'll give them biochemistry. We'll give them, whether you are smoking, whether you are living, in Colorado, in high altitude, low altitude, whatever, is pathology report, biochemistry, everything, into the basket. And then you will ask, tell me, what I am the subtype. And plus you will give them omics. Omics means that, for example, about mutation, about, whether you have, some immune cells, from pathology report, what is your, for example, imaging. You can, take the imaging study, okay, tell the doctor, because it's yours, you pay for that, okay. You take, the X-ray, CT or MRI, you load it, okay, there. So they will immediately, the artificial intelligence look at everything, your tumor, what is, about the tumor, how big this tumor, homogeneous, heterogeneous, everything will be there. And then, will help you, so, and of course, for us, for physicians, we will need, large scale, which means we will need a lot of, how to say,
Come on, Dr. Pacak.
yeah.
So, we only have these rooms until 2. So, I want.
It's okay, I will speak
You
up.
can continue talking outside. I
Yeah.
just want people to eat.
It's okay, so what time is it?
It's fun. We have 20 minutes.
Yeah, okay, give me 5 minutes. So we will have this one. So we will be creating actually this. We will be creating this model. We will create it also on the imaging. Sooner or later, we will be so far that on the base of the imaging, we will tell you whether you have a chance, to recur or to metastasize. Is it? That's something, exactly, because every day you wake up and thinking what will happen, and every day you go back and think about the same. It's true, yes, and the same like we have something, that I also went through several operations because of some other problems. So, and you are always thinking that will give you, some help. The proposed novel compounds to treat metastatic disease. Again, the information will be needed. But what is the cool is this: predict resistance before it clinically emerges, to identify actionable target for rational sequencing of therapies, which means, it will be giving, something based on the artificial intelligence before actually, or at certain time, before actually you can develop resistance. Why patients, with chemotherapy are failing? Because the resistance is coming, and plus they have an adverse effect. And this is even, even cooler. What would likely have happened if we would have chosen a different therapy? I think it's marvelous. It's marvelous. They will give you, this type of therapy, and before giving to you, they will say, okay, we will simulate for this patient based on his mutation or her mutation, age, blah, blah, blah. What about if we do this one versus this? And they will actually simulate, the clinical trials and finally tell you, maybe you are not very good candidate. These days, nobody will tell you. We have this one, based on this is, the first line of the therapy. You will get it. Come in 3 months. If you are not doing well, because we do CT and MRI, if it is changing, we will do something else. Okay? So, of course, and to simulate new virtual trial arms. Virtually, we'll be doing, how you would do if, the combination of drug would be different. And the last one, I think, is this, it's very complicated, but I just wanted to tell you there are options how we will be changing, your tumors from the cold to hot, and how will we published just now this one. It's called Black, Exposed, and Immunized Triple Attack on the Cancer, which means not only immunized, but the cells are coming, from the cancer. Yeah? This is, everybody is afraid I have a metastatic disease or I will develop metastatic disease. So we will be using drugs. They will decrease migration, migration, from the primary tumor, somewhere else. And we will have also like red light, so that will go to the tumor, and we will give, the drug that will, based on the red light, will change the conformation and will be much more potent inside the tumor. And it's nothing. You don't even feel it. Nobody actually even touch you practically. There is a red light, so I think that will be good. And you all will have something which is called a personalized card in the future. And automatically this personalized card, will go through the computer like, these days, the computer is, if you have a program, so it's automatically is updating, your, I don't know, whatever you have, playlist, for example, or I don't know. It will automatically doing based on, information that will be constantly receiving, from clinical trials, from, the data that were published, the world's conferences, everything. So you will know immediately what are my options for the treatment at the present time. What, and every week, every 2 weeks, it will be, it will change. So that, I think, it's practically everything, because you are hungry.